Phases of Streptococcus pyogenes. This is a well-known bacterium. Now I can see it. Sorry. It lives well with humans. It colonizes the upper airways very frequently, and it usually causes GP-level diseases, like all kinds of airway infections and a wide variety of skin conditions, from superficial to deeper layers. An all-out scarlet fever can cause problems later, even decades later, through autoimmune mechanisms, glomerulonephritis or rheumatic heart disease. What's more important now are the invasive infections that can be severe, systemic, and very quick. So we also need to be very quick. We've all treated toxic shock syndrome patients, and probably all of us have seen necrotizing fasciitis. How do I go on? Okay, now I can't change the picture. Okay, thank you. Okay, when do we talk about invasive streptococcus infection? First, we need a patient who's bad enough for hospital admission, and we need a diagnosis out of these, the followings, and we need to suspect Streptococcus pyogenes in the background. If we have a suspicion, we like to prove it, so microbiology samples are very important. Also, the patient usually has contacts, and we have to warn them to look for symptoms, and chemoprophylaxis is also needed for them. Okay, who's this guy? He's a gram-positive spheroid bacterium causing beta hemolysis, and it likes to form chains and generates pus. Originally, it was classified as group A by Lansfield. Nowadays, we use the M typing based on one of its surface proteins, the M protein. We know about more than 150 serotypes. It colonizes the upper airways. Up to 20% of kindergarten age kids carries it, and half of the population living with them. It's easily transmitted via droplets, and luckily it's usually susceptible to penicillin and beta-lactams with inhibitors and cephalosporins. Why do we talk about it now if it's easy to treat and very common? Because the epidemiology is changing. WHO recognizes 18 million cases worldwide annually with 500,000 deaths. Most of the cases occur in the overcrowded, hygienic areas of the world. Extremes of the age are at greater risk, with immune-compromised cases more so. Viral infections and other comorbidities pose a risk, and chronic steroid use is also something you should be worried about. Case numbers are on the rise. There is a natural cycle in strepto infections, with new people being born all the time. They are strepto-virgin, but this growth in incidence exceeds this natural cycle, this 5 to 7 fold increase. No new serotypes were identified. We theorized that reality follows theory, that we spent years in isolation due to COVID, and the population is moving. Now we were not exposed to the usual bacteria and viruses, so we are more prone to infections. Okay, this little warrior has all kinds of defenses. Its capsule makes it durable. The virulence factors help it to stick to tissues, to hide from the immune system. And using antigen mimicry, it confuses the immune system, and later on it can cause the autoimmune reactions. It has active weaponry with which it can defend itself, dysregulate the immune system and cause hemolysis. Some of these toxins can behave as superantigens, meaning they bind to T cells specifically, causing a dysregulated immune reaction and a huge cytokine efflux. And now these cytokines are interacting with not only the immune system but with the hemostasis, as it was discussed before. So bleeding and thrombotic complications can occur. So where do these bacteria get in our system? There are the common pregnancy-associated and soft tissue infections, and a lot of rare gateways where it can get in the system. And with the rising numbers, we are seeing the more and more rare cases. Here are some of our cases from 2022. These were all intensive care patients with the focus in color. The green ones are the common causes and the red ones being the rare causes. We had pretty much patients with rare causes. Okay, 2 cases I brought you from 2023. Case number 1 is a young woman with no comorbidities, but with 3 kids from breastfeeding to kindergarten age. She presented in an emergency department with general weakness, cough, fever, and shortness of breath. She was examined, lab results came back, nothing extraordinary. She was sent home, get rest, get well, it's probably something viral. But in 2 days she got worse, came back, and she had hypoxia, hypocapnia, some lactate elevation, extreme white blood cell count, CRP and procalcitonin, also some elevation in D-dimer and anemia with low platelet count. They were looking for pulmonary embolism with these findings, but it was not found. So they started ventilation, they started supportive care, and took samples from every possible place, including airway PCR. That's a very good move because it was fast. Within hours, it was reported that it is our body's Streptococcus pyogenes. So antibiosis was altered accordingly. As she was in massive septic shock, we suspected superantigens, so ceftriaxone was combined with clindamycin. We consulted our infectologist, and in a few days, when the massive shock was over, we could de-escalate to penicillin G. Okay, the clinician in charge saw this massive septic shock, combined circulatory support was needed, and obviously we couldn't remove the focus, her lungs, so we theorized that the patient will benefit from immune modulation or recharging the immune globulin. So we used intravenous immune globulin. The patient got better from all of this. Also, we had some other findings. These were our side quests. Upon admission, we found some repolarization anomalies. We had elevated troponin, and we had a history of chest pain. So we invited a cardiologist who performed ultrasound and found good cardiac function. No acute coronary syndrome was diagnosed, and the ECG healed parallel with the patient. Also, I forgot to tell you about pus generation. Okay, yes, pyogenes likes to create all kinds of effusions, bullae, systemic edema, and now pleural effusion. Pleural effusion is a bit underreported, but common consequence of pneumonias. And pyogenes very much likes to generate pus. Sometimes explosive pleural fluids are reported, which means a huge excess fluid in 24 hours. This time it took a few days to be big enough to be drained, and eventually we had to drain it. and the patient got, the ventilation got easier. Also, there were talks about coagulation anomalies. We had no problems with this patient. She had low scores for DIC or SIC, but we've all read about this. We've all seen thrombotic complications during COVID. So we have a ClotPro machine and we perform tests. You can see that the fibrinolysis was impaired. It has a longer lysis time. Higher dose, low molecular weight heparin was applied, but nothing to do, only observe, and the TPA test normalized as the patient got better. And a huge thank you to all our team, because it's not over with the diagnosis, it's not over with antibiotics. You need to get well, you need to recover, and this patient had a massive muscle mass loss. She had a bad case of delirium and a long period of depression, but she got well. And now for something completely different, the Streptococcus pyogenes, now staring in a meningitis case. This patient was is a middle-aged kindergarten teacher with no significant comorbidities. She was found at home unconscious, aspiration was probable, and the ambulance crew found anisocori. They started ventilation and other supportive care, circulatory support. She was transported to our intensive care unit, where obviously we performed the cranial CT, and the other lab findings supported a huge inflammation, hemolysis, impaired coagulation. She had an elevated creatinine, but it did not cause any problems. On her CT, maybe you can see there was a middle ear infection with all the sinuses, with pus in all the sinuses and the mastoid cells, and she had intracranial air and some fluids, which was reported to be blood the first time. So broad spectrum antibiotics were started, and this time we had to wait a few days for the microbiology lab without PCR to report that it is a Streptococcus pyogenes. And after that, we could de-escalate the broad spectrum to ceftriaxone. This time we didn't think it necessary to block the toxin production because she was not in septic shock. Only a short period was with circulatory support, and she got better. Also later, she had secondary infections, but that's another tale for another time. Upon admission, we found these pus pockets, ear, nose, thoracic. Okay, ENT surgery was available, and the sinuses and mastoid cells were evacuated. On the control CT, you can see they are beautiful and clean, but the intracranial fluid grew. We thought possible that it is pus, and also the tonsils were moved towards the foramen magnum. We consulted neurosurgery, and they accepted the patient. Craniectomy and the evacuation of empyema was necessary, and it was done. Quite a bit of her head was missing after that. You can see it was really bigger pressure. She eventually got better. All she had to do was to recover from this roller coaster of secondary infections, loss of muscle mass. She had to learn to talk and walk again. And a huge thank you again for the whole team, even the surgeons. So she got better, and since then the reconstruction surgery also took place, and she's without any remaining symptoms. So what I wanted to say is that Streptococcus pyogenes is on the rise, case numbers increasing, and with these bigger numbers we see unlikely sources more often. We need to act quickly. We need to collect samples from every possible place, and having an infectologist at the bedside in itself lowers mortality. If the patient doesn't get better, we need to reconsider if we have missed anything or any place where pyogenes can hide, because if we don't look for effusions in a focused manner, we may miss it between layers, or as it was reported to be blood in the head of this woman. We need to reconsider and evacuate everything that we can so that the patient can heal. Thank you for your attention.
Thank you, István.